So, obstructive sleep apnea or sleep apnea in general is a huge topic, and I'm trying to gear this tonight to lay people. There's a lot of medical information that I could discuss, but we're going to try to leave aside since most of you are not medical professionals. But I can certainly answer questions at the end if people do have more specific questions about sleep apnea or Inspire technically. What we'll cover tonight is what is Inspire in general, how the surgery is done and what the recovery is like, who is a candidate for Inspire therapy, the risks involved with Inspire therapy, insurance coverage issues, and then at the end, something I haven't done with previous presentations is that we'll actually talk about a presentation of an actual patient. Inspire is an implanted system that we put in the body that stimulates a nerve that moves the tongue. And that nerve tells the tongue to move forward. And by doing so, it opens the airway in the back of the throat. This activation occurs during inspiration when you're breathing in. Patient turns this on at night with a remote control and then turns it off during the day. So it's completely off during waking hours. There are three parts to the Inspire system that are all implanted. And the first main part we call an implanted impulse generator, which gets placed in the right chest in a pocket overlying the muscle in the chest. There's a second component, which is a stimulating electrode that gets placed on the nerve that moves the tongue, called the hypoglossal nerve. That's placed through an incision just below the right jaw. And then there's a third component, which is placed through the same incision that we placed the unit in the right chest. And that third device is a pressure sensor, which is placed between two ribs within a layer of muscle to detect when a breath is being taken in. And this way, when inspiration or breathing in is detected, an electrical impulse is sent to the hypoglossal nerve, which causes the tongue to protrude and move forward. And this prevents the throat from obstructing. One of the big questions that people ask is, how does it know when I'm having apnea, and therefore it knows when to send a signal? The answer is, it doesn't. We're not waiting for apnea. Apnea is, by definition, a 10-second obstruction. And if you've waited that long, you've already missed the boat. You've already had an apnea. So Inspire is simply moving the tongue forward out of the way and opening the airway so that there are no apneas. This is a schematic that's now antiquated. As Ben mentioned, I was one of 4 surgeons who began to develop this alternative surgery where instead of creating 3 incisions, we were able to consolidate the procedure into 2 incisions. And so, let's see if this is also a pointer. Probably. I'll point right over here. This part right here that you see going down here, this part has been removed, not removed, but moved, so that it's also placed at the same incision where the IPG is placed. And it eliminated the 3rd incision that was on the chest. That was the innovation that I was involved with. You can see on the right side of the screen the timing of the impulse. It's basically about mid-exhalation, the impulse is started, and that continues through the entire inhalation part of breathing. It has a battery, and the battery will die, and it's not rechargeable. So when the battery dies, the whole IPG, meaning the generator itself, but not the other 2 components, will have to be replaced. The projected battery life is 10 to 12 years. Patients who were in the early trials of Inspire therapy before it was FDA approved are now just beginning to hit that 10 to 12 year threshold. And so the very first patients are coming around now to have their IPG replaced. That part of that procedure will be very minor since we're not touching the main things, which are the stimulating electrode and the pressure sensor. This is a great slide that I actually show with medical professionals because it shows both schematically in the top part of the screen, but also on the bottom part of the screen. These are actual videos of patients on the split screen here, the left picture on both sides here is without Inspire therapy. You can actually see the airway obstructing, and then on the right side, you'll see what happens with Inspire and how it opens the airway. The left panel is going to show the level of the throat where the tongue is, the base of tongue, and on the right side here is at the level of the palate, which is the roof of the mouth. On the right side with therapy, it's the same places, but with therapy. So we'll play this here. And so here you can see the airway is this little black part here. That's where air flows. So the airway is closing off completely because the tongue, this is the back of the tongue right here, and this is a cartilage called the epiglottis, which is above the vocal cords, are completely closing off this person's airway. This one on the right side is taken a little higher up at the level of the roof of the mouth, where basically the nose meets the throat, and you can see there's no airflow. This space here is completely closed during the apnea. And this person is trying to breathe, by the way, but they can't get any air through. Now we're going to turn on Inspire, and you can see dynamically that's on. And then exhalation at rest, and then on. And you can see how that space, which was completely collapsed on the left, is now open with each inhalation. Same is also true for at the level of the palate. You can see off and then on. You can see that opening, which is created, preventing collapse and allowing air to flow. And it really does look like this. When I look at patients when their Inspire is turned on, this is exactly what we see.
Is it muscle stimulation of that particular muscle?
It's indirectly. So Inspire doesn't interface directly with the muscle of the tongue and throat. It does not. There's no connection directly to the muscle. We're placing it on the nerve that stimulates the muscle. So if you were to stick your tongue forward right now, that nerve is activated. Exactly. This stimulates that nerve. So it's basically doing what your body would do if you were to push your tongue forward, but not stimulating the muscle directly itself. It's just telling the nerve which moves the tongue to move your tongue forward.
So there's no attachment to a nerve. There's no a medical attachment, anything to any muscular tissue.
Not to the tongue. No, your tongue is not involved. We don't touch your tongue during the operation. The only thing we do with your tongue during the operation is we do insert a couple of needles into the tongue. And those needles monitor electrical activity in the muscle of the tongue because we use that information to guide us in the correct placement of the electrode on the nerve. We are specifically placing the electrode at the point on the nerve where the only parts of the tongue we're stimulating are the protrusion parts. Other parts of your tongue pull your tongue back to your throat. And if we were to stimulate that part of your tongue, at best, it probably wouldn't help your sleep apnea, and at worst, it could actually make you worse. So we're selectively placing it, and to do that, we have to monitor activity in the tongue muscle. So we have a couple of needles in there which are removed at the end of the procedure. But we don't. Otherwise, there's nothing. Doesn't affect your tongue. So daytime, speaking, swallowing, no effect on the tongue. You wouldn't know you have it. Procedure. I wrote 90 minutes here. This is, I think, an old slide. My average time is about 60 minutes now. What? About 60 minutes, 1 hour. And as I said, it used to be 3 incisions. It's now 2. Always the right side. It's an outpatient procedure, and pain afterwards tends to be minimal. Most patients don't have significant pain. I generally don't prescribe what we call narcotics. We usually use non-narcotic pain medicine, and for most people, with occasional exceptions, that's sufficient. Light activity for 2 weeks, otherwise no physical restrictions after the procedure. And after the 2 weeks, there are no restrictions. So weightlifting, swimming, climb camelback. So who is this for? First, this is for people with really bad sleep apnea. This is not for mild sleep apnea. So mild sleep apnea, we don't treat with Inspire. For moderate to severe sleep apnea, that means if you look at your sleep study, the AHI, which is the number of obstructions per hour of sleep needs to be somewhere between 15 and 65 for most plans. Body mass index, which is a measure of weight and height that relates the two together, has to be less than 35, but for most commercial plans, it has to be under 32. That means if you're really heavy, this probably isn't going to be an option for you. I have adults, I have to change this slide over 22. It's now down to 18, right? Unless you have Down syndrome, in which case it's down to, I think, 11 or 12%. And most importantly, this is for people who don't tolerate CPAP. If you are using CPAP every night and you're sleeping through the night with your CPAP, you should not even be considering Inspire. We have to have a sleep study within 2 years prior to surgery. Central apnea is different from obstructive sleep apnea because central apnea means your brain is not actually initiating a breath. If your brain doesn't initiate a breath, you don't take a breath, and Inspire won't help because it doesn't tell your brain to take a breath. That's a different kind of sleep apnea. And some people have a little bit of both, and that's okay, as long as the proportion of central apnea, which is the failure to take a breath, is less than 25% of the total apneas and other blockages. And then you cannot have what we call complete concentric collapse of the airway at the level of the roof of the mouth or soft palate when we perform sleep endoscopy. We'll talk about sleep endoscopy in just a second. Sleep endoscopy is required by the FDA, so we can't omit this step. This is done in an outpatient surgery center prior to us moving forward with Inspire. So this is a prerequisite to get Inspire. We provide IV sedation similar to what someone might get for a colonoscopy. And once a person is sleeping, they will begin to snore and exhibit sleep apnea because, after all, that's what they do when they're asleep. Once we see that, I insert a flexible endoscope through the nose, and we look inside the throat at multiple levels within the throat to gauge both the nature of collapse as well as the level of collapse. We divide the level of collapse into 4 different levels in the throat, and we're looking for a specific pattern of collapse which wouldn't benefit from Inspire, and there's only one, and making sure that you don't have that. If you do have that pattern, which we call complete concentric collapse, then unfortunately you would not be a candidate for Inspire. Overall, this comes out to about 10 to 20% of patients will have this complete concentric collapse and not be candidates for Inspire. Having said that, there are some other surgical options for those patients who have that complete concentric collapse that I do perform. So it's not necessarily the end of the road for those people. In the published literature, which is numerous on Inspire, we have well over 100 published studies documenting the safety and efficacy or effectiveness of Inspire. Overall success rate is in the 80% range. 80% is an interesting number. It's really high compared to many other forms of treatment for sleep apnea. It's certainly higher than other older procedures that have been around for much longer, but it is most certainly not 100%. And what that means is that there are going to be some people with our current technology and our current screening process to determine who is a candidate for this. You can meet all of those criteria. You can go through the screening process. You don't have complete concentric collapse. We've done everything correct. You can get Inspire, and there's still a 1 in 5 chance that you'll have less than adequate response to Inspire. Statistics from my own patients, which we track very carefully. My average preoperative AHI, which is that number of times per hour that people stop breathing, average for me preoperatively is 34, which is severe sleep apnea. My average post-op is 6. So average improvement in reduction in sleep apnea in their apnea is about 80% or 85%, something like that. 5 years after surgery, if we reach out and look at people who have received Inspire to see who's actually using this, we see that about 90% are still using their Inspire 5 years after receiving. If you compare that to CPAP, which most people here are probably familiar with, that number for CPAP is anywhere from 40 to 60%. Complications or risks. I've not seen this much, and I have to really go out and talk more with patients who are using this a while to see if anybody's complaining of this, but tongue-related discomfort from the tongue just moving in and out of the mouth is reported in 8 or 10 to 12% of patients. Usually not severe and can be dealt with if that happens, but that's probably the most frequent complication. There are very rare instances of weakness of the tongue from manipulating that nerve, and in all cases, to my knowledge, it's resolved. I don't think there's anybody anywhere who's had a permanent paralysis of the tongue. Temporary air leakage into the chest while we're inserting the pressure sensor can occur. It's a very, very rare complication. I've actually had this occur on one occasion, and it was fixed and resolved, but it's a potential risk. Bleeding or infection after surgery is rare but can occur. And problems with any of the components of the system. We have these 3 components, the IPG, the pressure sensor, the stimulating electrode. Any one of those 3 may develop a fault or problem at some point and require replacement. And I've had a handful of these. So in my practice, that has been the most frequent complication, and that simply means we have to replace one of those components. Coverage has gotten better and better over the years since I've been involved with this. It's now covered by pretty much all plans. That was not true a few years ago. So how does this work? Let's assume somebody goes through the process, they are a candidate, they get the surgery. The first 4 weeks, we don't use Inspire, it's completely off, and that allows the body to heal. After that, it's activated in the office of their sleep medicine provider, and they're started off on a low-level therapy at level 1. Level 1 simply means a relatively low voltage level that's going to deliver very little stimulation. So little that it's not effectively managing their sleep apnea. But it's just enough for their body to begin to get used to this therapy so that when therapy turns on during the night, it doesn't wake them up. And assuming that level 1 is not waking them up at that very low level of stimulation, the patient then, using their remote control, raises the level up to level 2 and making sure that that's tolerated. And every 4 or 5 nights, as long as therapy is not interrupting sleep or hurting, continues to adjust their therapy all the way up to level 10, or at least somewhere in the 7 to 10 range where we know they're tolerating therapy. Usually during this process, it may be at level 3, it might be at level 5, patient and their sleeping partner will often begin to see that the snoring is beginning to go away and their sleep apnea has disappeared. They usually start to feel better in the morning, indicating they've had a better sleep. At that point, once we're tolerating therapy, we're using it all night, we're at 7 or 9 or 10 on the remote. At that point, we want to actually perform a sleep study using Inspire therapy to determine how effective it's working for them and make any further adjustments to therapy at that point. And then the remote is reprogrammed and they go out on potentially different settings. It's not uncommon for people to further self-adjust. So we do this first sleep study. It might be 60 days after the procedure. It might be 90 days. We might still see some mild sleep apnea. But at this point, let's say the patient is on level 7 or level 6, not really tolerating going much higher than that, but we're still seeing some mild sleep apnea at that level. Then we still want to do some more self-adjustment at home where the level is going to be raised up a little bit more and hopefully get them to a complete resolution of their sleep apnea or at least a maximal reduction in their sleep apnea. We then want to follow up with a full night sleep study, either at home or in sleep lab, once we've arrived at that final therapy level, whatever that may be. And this is usually 6 to 12 months after the surgery to get a final check on how well is this working. It's important for the patient because ultimately you don't really know how your sleep apnea is doing unless that's verified. And secondly, it's important for us to verify that we know how effective the therapy is. Okay, I'm going to present a case of Michelle. I won't share her last name. This is a real patient of mine that I implanted about a year ago. Michelle is a 40-something-year-old female with severe sleep apnea. Her HI is 43. So that puts her well into the severe range. Severe starts at 30. She's at 43. Our oxygen levels drop to as low as 83% while she's sleeping. And probably just as importantly or more importantly, she spends 22% of the night with low oxygen levels. That's problematic. Without going into all of the physiology of oxygenation in the body, I think we all implicitly understand that all of our tissues require oxygen. To have low oxygen for more than a fifth of the night is, in the long run, going to be very detrimental to her health. She was diagnosed about 5 years ago. Unfortunately, even though she's tried multiple CPAP masks, she's tried CPAP on multiple occasions, she either can't fall asleep with it, and so she turns it off, or she turns it on, and then she wakes up and she can't get back to sleep, and then she turns it off again. Like a lot of people who don't tolerate CPAP, she's got a little bit of claustrophobia. And so the idea of putting something on her face makes her anxious. And she'll often lie in bed for hours trying to fall asleep with the CPAP. And even when she uses it because of all of the frequent awakening that's occurring due to the CPAP, trying to use the CPAP and lying awake trying to use the CPAP. She gets up the next day feeling extremely tired, and she's sleepy during the night. She also tends to breathe with her mouth at night, which is a problem. She's a mouth breather. So I saw her in the office and saw that her nasal blockage had a reason. She had enlargement of something we call turbinates inside her nose. Otherwise, really no other major pathology. And looking in her throat, in her airway, the best assessment that I could do in the office suggested that her tongue was likely the cause of her airway obstruction. The back of her tongue was probably blocking off her airway when she was sleeping. So I took her to surgery to do the sleep endoscopy, not to do Inspire, but we have to do that first step. And we did actually see that her tongue and the lower part of her throat were actually, as I thought, the cause of her sleep apnea. She really had no significant side-to-side collapse, and complete side-to-side collapse is what people with that complete concentric collapse have. So we made sure she didn't have that, and she didn't. So she was a candidate for Inspire. I also, at that time, during the sleep endoscopy, reduced the size of her turbinates in her nose so she could breathe better through her nose. And I do that a lot, not in every case, but in patients who have difficulty breathing through the nose, because regardless of what comes after, if someone fails the sleep endoscopy and they can't get Inspire, or they pass and they do get Inspire, closing the mouth at night and getting somebody to breathe through their nose is beneficial to their sleep in general and to their sleep apnea specifically. 3 weeks later, she had the Inspire system implanted. Surgery in her case took 50 minutes, and she went home the same day. She was activated a month later, according to protocol, and she gradually increased her therapy level to level 7. At that point, at level 7, before even her sleep study, her sleeping partner reported that her snoring had resolved, and she was typically only waking up once during the night versus several times before. And she was averaging, and we can determine this from downloading data from her Inspire system, she was now averaging 6.6 hours of Inspire therapy per night, which was far greater than we were getting. Her post-op sleep study revealed her AHI had diminished to 4 with Inspire, 43 per hour. 4 is normal. Less than 5, 0 to 4 is normal, so she's now in the normal range with Inspire. However, occasionally her oxygen levels still drop into the 80s, but the percentage of time below 90% was reduced from 22% to 12%. Since that study was done, and I don't have a follow-up sleep study yet on her, she has actually bumped her level up a couple more times. And so hopefully these numbers are better than what we got in the sleep study. So there's lots more to talk about, and I'll answer questions in just a second. I'll just leave this up here. For anybody here in the room who doesn't have a diagnosis of sleep apnea or suspects you may have sleep apnea, what I recommend actually is starting with Valley Sleep or a sleep evaluation to determine if you have sleep apnea before coming to see me, to see if this is even something that we should be talking about. And if you haven't been diagnosed with sleep apnea, then by definition, you haven't tried CPAP. And I really do want everybody to try CPAP before coming to see me, because even though people in their minds will often say to themselves, I know I'm going to hate that, and I know there's no way I'm going to be able to sleep with CPAP. It's amazing. Sometimes people surprise themselves. And people may be very successful CPAP users, and if that's the case, we should not be discussing Inspire with you. So that's always the first step if you haven't been diagnosed with sleep apnea. However, if you've already been diagnosed with sleep apnea, and you've already been through CPAP, and you're here because you don't tolerate CPAP, and especially if you've already stopped using it, then you can certainly call my office and schedule a consultation, and then we determine, based on your exam, based on your sleep study, and so forth, if you're a candidate for Inspire. That's it. So, I'll open the floor to questions here. Yes?
This process can be reversed.
The entire system can be removed. If someone was not benefiting from therapy, you wouldn't necessarily have to remove it because it's essentially not doing anything in your body and you just not be turning it on. So you wouldn't have to have it, but you could.